So that was about the part 1. Let us begin part 2. We are going towards the airway diseases, asthma, COPD, bronchiectasis, and pneumonia. So bronchial asthma, since you all know the definition part, it's a chronic inflammatory disorder, but there is a variable and variable. Variable is very important and reversible airflow limitation. Okay. So the key cells are eosinophils. Yes, there are other cells other than eosinophilic also. So we have non-eosinophilic asthmatic. So pathophysiology, the 3 important aspects: airway inflammation, airway hyperreactivity leading to airway obstruction. In the initial phase, it is reversible, but in the later stage, it can become fixed. Symptoms, you know, episodic wheeze, cough, dyspnea, and chest tightness. And these symptoms are worse. That is one important clinical point. Worse at night or early morning or with triggers. And triggers are exercise, allergen, cold, and viral infection. So the classical picture of this asthma is intermittent symptom, which vary in time, and they have a family or personal history of atopy. Spirometry, already mentioned, the significant bronchodilator reversibility. If there is no spirometry available, peak expiratory flow rate variability should be more than 20% day-to-day variation, or FeNO, fraction of exhaled nitric oxide, which should be more than 25 parts per billion, suggestive of airway eosinophilia. This is a symptom-based severity or control classification, where the daytime symptoms, if they are less than 2 days per week or more than 2 days per week. If they are daily, then they belong to severe. Nighttime awakening, if it is happening more than 1 night per week, it belongs to severe. And activity is markedly reduced or daily limitation is there. And the use of reliever, that is the SABA-ICS combination of many times in a day, then it belongs to severe. So these 4 parameters are very important to assess the control or the severity of the asthma. So these 2 are important for assessing the control as well as the severity of the asthma. Asthma management, as per the guideline, we have a SMART therapy, that is SMART therapy, single maintenance and reliever therapy. The single inhaler can be used, which is containing of inhaled corticosteroid and a long-acting beta-2 agonist, that is formoterol, as a MART therapy. So step 1 is mild as needed. Step 2 is low dose. Step 2 and 3 is low dose. Step 4 is medium dose. And step 5 we have to consider for high dose, as well as if it is dependent or if it is resistant asthma, then we have to think of biologics. Okay, so this is how we are going to classify the asthma management. So asthma exacerbation, the red flag signs are: patient will not be able to talk in a complete sentence, tachypnea, tachycardia, hypoxemia, and if PEF is available, less than 50% of his predicted value. Okay, along with that, CNS involvement, confusion. These are all red flag signs. So what are the immediate steps? Yes, definitely here we can give very high flow oxygen. We can maintain saturation of 94 to 98 with the help of short-acting beta-2 as well as muscarinic antagonist. Systemic steroid do have a role for a short period of time. Okay, and oxygenation needs to be continued with the monitoring of peak expiratory flow rate and ABG if the condition worsen, and you have to reassess early, 1 hour, if there is no improvement. What if there is no improvement? You can step up, escalate the medications to IV magnesium sulfate, IV methylxanthine, and if the PaCO2 is 45 and pH is coming up to 7.35, then it is impending failure. Why it is important? Because in the initial phase, there is tachypnea. Tachypnea leads to washout of carbon dioxide. Carbon dioxide will be falling down and pH can go little on the higher side because it presents with respiratory alkalosis. Because of this fatigue, respiratory muscle fatigue, they may go into impending respiratory failure, and that starts building up the carbon dioxide and pH will come down. So any severe asthmatic patient, if you see a normal PaCO2, that is suggestive of impending respiratory failure. So please act fast when you see a PaCO2 normalizing in an acute asthma patient. Okay, an intubation needs to be done if there is exhaustion, altered mental status, or rise in CO2 despite the optimum management. Coming to the next airway disease, chronic obstructive pulmonary disease, which is again here, there it was a variable intermittent, but here it is persistent. So that's why I have added only keywords. So persistent and it is progressive. Okay. Here also there is a chronic airway inflammation, but along with that there is a parenchymal destruction. So various etiologies are there in COPD, the most common being environmental exposure, that is tobacco or a biomass in case of females. And we have host factor, which includes genetic development or airway hyperreactivity, certain early lung growth abnormalities or prior childhood respiratory infections, and other chronic airway diseases like bronchiectasis or post-tuberculosis. Always screen for alpha-1 antitrypsin deficiency in case of early onset or non-smoking COPDs. Diagnostic criteria already mentioned: post bronchodilator, post bronchodilator. Very important is to stress about this word: post bronchodilator. FEV1 upon FVC should be less than 0.7, confirms there is persistent airflow limitation. How do you assess the severity? There we had 4 important parameters. Here we have COPD assessment test, which measures the symptom burden. And to assess the dyspnea, we have grades of breathlessness 0 to 4 and exacerbation history, which will help you to assess the risk of future events. According to the guidelines, gold guidelines, barometric staging has been done depending upon the FEV1, mild, moderate, and severe, and very severe. If the FEV1 more than 80% belongs to mild. If the FEV1 falls below 30%, it belongs to very severe. So this is a pharmacological management as per the gold criteria, latest guideline. Initially, there was group A, B, C, and D, but now they have clubbed C and D and made it as a group E, which is very severe group, which is having more than 2 moderate exacerbation or 1 which is leading to hospitalization. And the MMRC grading is irrespective of that. MMRC, whether it is 0, 1, 2, 3, 4, no. If there is more than 2 exacerbation or 1 exacerbation leading to hospitalization, they directly belong to group E. Okay. If they are having mild exacerbation history and mild breathlessness and CAT score of less than 10, they belong to group A, and they can be started with A bronchodilator, either LABA or LAMA. So there is no role of inhaled corticosteroid in the mild COPD. Okay. And we can define chronic bronchitis as productive cough for more than 3 months in 2 consecutive years. So this is a classical definition of chronic bronchitis. So when to ask CT thorax in a COPD patient? Normally, we don't ask straight away CT thorax in a COPD patient. If we are suspecting bronchiectasis, if patient gives history and symptoms of bronchiectasis, yes, definitely the CT thorax can be asked. And when the symptoms are out of proportion with the severity of the disease, when the patient is telling mild COPD history and the symptoms are very out of proportion, definitely you can go for CT thorax. If you are suspecting lung malignancy, because both COPD and lung malignancy has a sharing risk factor of tobacco smoking, and pulmonary embolism, it's a high risk because of the polycythemia. Patient of COPD and chronic smokers have polycythemia, and that is one of the risk factors for pulmonary embolism. If you have features of pulmonary embolism suspected, you can definitely go for CT thorax. So pharmacological management, we have bronchodilators, long-acting beta-2 agonist, and long-acting muscarinic antagonist. These are the bronchodilators needs to be used. There are definitive indications for inhaled steroid, which includes blood eosinophilia of more than 300, and there is history of asthma overlap or frequent exacerbation despite giving dual bronchodilator. So triple therapies are mainly reserved for group E or these 3 category of the patients. And methylxanthines as well as roflumilast, azithromycin, they act as an add-on or supportive in certain subset of the patients. Along with pharmacological, COPD also has a non-pharmacological treatment role. Smoking cessation is a most effective intervention, because if you just stop smoking, the progression will reduce. So always remember, the progression will not stop, the progression will slow down. Okay. And pulmonary rehabilitation in the form of deep breathing exercise, limb exercise, vaccination definitely in order to avoid recurrent infection and exacerbation. And if the patient is severely hypoxic, then long-term oxygen therapy also has a better role, because if you don't give oxygen therapy, just treat him with the medication, again, the mortality and the quality of life is not that great. So this is a classical chest X-ray of a COPD patient. You can see hyperinflated lung field, tubular heart, okay, and the diaphragms are almost flattened here. You can see the diaphragms are almost flattened, okay. So this is a CT. You can see the black shadows. Okay, these are vessels, and this is a destructed area, emphysema. Okay, black shadows, and this is a centriacinar because it is in the center, and these are paraseptal. Okay, along the septa there are emphysematous changes. You can see here paraseptal emphysematous changes. The risk with these paraseptal emphysematous changes is the patient can present with pneumothorax. So coming to acute exacerbation of COPD, it is acute worsening of respiratory symptoms which require treatment change, and that we need nebulized bronchodilators, systemic corticosteroids, and targeted oxygen therapy. So always remember, targeted oxygen therapy is must. Okay, in patients who are having acute exacerbation of COPD, the saturation target should be 88 to 92. Okay, and you have to take an ABG in 30 to 60 minutes after starting O2. So you always avoid hyperoxia. And NIV is indicated if the pH is less than 7.35 and PSO2 of more than 45. Mechanical ventilation if patient does not respond to optimum treatment and NIV support. So just to complete asthma and COPD, there's a differentiation of asthma and COPD here. Asthma is a disease of young age. Usually it begins with less than 40 years. Yes, there are certain patients which we see as late onset asthma, but COPD is usually a disease of old. And if you suspect COPD in the early, the alpha-1 antitrypsin deficiency should be screened. Already discussed, it is episodic, it is progressive and persistent. Here there is complete reversible. Here there is partial reversible or fixed depending upon the severity of the disease. Trigger can be allergen, cold air, or exercise infection. Here the risk factors are smoking, biomass fuel, and occupational exposure. The comorbidities are allergic rhinitis, eczema, GERD, obesity. Here the comorbidities are little serious: cardiovascular diseases, cachexia, osteoporosis, anxiety, and depression. Why it is important to mention about comorbidities is they are also one of the triggering factor for asthma. Despite optimum treatment, a good inhaler technique, and a good control asthma can be triggered by comorbidities. So always keep a mind of comorbidities when you are suspecting an acute exacerbation of asthma.